Good evening, friends. Sorry for the delay for a couple of minutes. I think Dr. Vidyadhar Kanhal and Dr. Sumita are in the same EC meeting. Whenever they are done, they will join us. So I warmly welcome the students for this evening. We have Dr. Vishwas from Professor SRB Sir's unit, KMC Manipal. And we have Dr. Madhusudan. He is kindly contributed by Dr. Nishikant sir, and he's from Alamin Medical College, Vijaypura. So we have two important exam cases for the day, the carcinoma of the thyroid and carcinoma of the cheek. So I request, the Madhu has some issues with this audio he's sorting out. So Dr. Vishwas will be presenting first. I also warmly welcome the invited faculty for the day, Professor Asif sir and Professor Pankaj Modi sir for joining us this evening. I also thank our faculty, Dr. Srinivasan sir, Dr. Karnakaran sir, and Dr. Rajiv Sahai sir for joining us. So friends, we will have the thyroid case first. Dr. Vishwas, please introduce yourself, your unit chief, your head of the department, and start your presentation. Faculty, kindly take over.
Yes, sir. Sir, good evening, sir. My name is Vishwas. I'm a first year general surgery PG, resident in KMC Mangalore. So my unit chief is Dr. Sriram Bhatt, sir. And our head of the department is Dr. Ashfaq Mohammed. So I'll go to the, shall I share the screen, sir?
Please. Go to the first slide, Vishwas.
Yes. Yes, sir.
You can start. Good luck to you.
Yes, sir. Thank you, sir.
Sir, can you hear me, sir?
Very well. But don't disturb. He's starting his presentation.
Okay, sir. Thank you.
Right. Go ahead, Dr.
Yes.
Vishwas.
Today my clinical case presentation is about swelling in the front of the neck. So patient details. So patient 70-year-old lady with ailing from Bantwala. Date of admission is in 29th June 2023, and date of examination is 29th June 2023. And chief complaints: patient presented to the OPD with swelling in front of the neck since 25 years. History of presenting illness: patient presented to General Venlock Hospital OPD with the issue of swelling in the front of the neck since 25 years. Incidence in onset, initially of small in size and progress to the present size. History of rapid progression in size in the past 8 months. No issue of pain associated with the swelling. No issue of dysphagia, dyspnea, hoarseness of voice, or stridor. So there is history of palpitation and generalized weakness. No issue of features suggestive of hypothyroidism. No issue of significant weight loss. No similar complaints in the family. No significant weight loss. For similar complaints, a patient had visited a nearby hospital multiple times where she got her blood test done, and the patient was put on oral medication. Patient was advised for surgery for the same, for the swelling in the neck, but the patient had denied and was managed conservatively. So past history. So patient is a known case of hypertension since 2 years and is on medication. Not a known case of diabetes mellitus, tuberculosis, bronchial asthma, epilepsy, ischemic heart disease. No issue of previous surgery. No issue of previous radiation exposure. Personal history: diet, she is a predominantly non-vegetarian. Appetite is normal. Sleep is adequate. Bowel and bladder habits normal and regular. And no habits of tobacco chewing or arecanut chewing. Family history: patient is firstborn and has 3 younger sisters. Patient is a mother of 4 children, 3 female and 1 male. No similar complaints in the family. Menstrual history: patient attained menarche at the age of 14 years and attained menopause at the age of 40 years. Previously, no issue of menstrual irregularities. Treatment history: patient for her hypertensive medication, she's on tablet Amlong 5 mg OD dose for past 2 years. And patient is taking tablet carbimazole 5 mg OD for past 2 years. General physical examination: 70-year-old lady, moderately built and nourished, conscious, cooperative.
Hang on. Dr. Vishwas.
That's what I said. Yes, sir.
We'll discuss on the history first. Could you summarize the history?
So, sir, a 70-year-old lady, sir, she came with complaints of swelling in the front of the neck since 25 years. And she has a positive history of positive history of these things, hypertension since past 2 years, sir, and on tablet. And she gives a similar complaints in the.
Vishwas. Hang on.
Yes, sir.
A summary of the history means that you just give us a brief of what her complaints are and what do you think could be the cause of that condition.
Yes, sir. So, sir, according to history, sir, it looks like patient.
Vishwas, sir is asking specifically a summary. We call it a short, brief handing of your history, not the diagnosis. You understand? I
Yes,
think
sir.
you did not prepare it. That's why you are in trouble. Okay, let us go to first slide. There should be a summary of history followed by whole summary. Sir is not asking diagnosis. What he is asking is summary, short, brief. So what are the salient feature of your history? Can you tell us? 1, 2, 3, 4. 1 is fine. That patient is having a swelling in the front and side of neck since 25 years. Okay. What are other important history?
And she gives a history of generalized weakness, sir, and the palpitations, history of palpitations. And
since how long?
Since past 2 years, sir. She gives history of palpitations since past 2 years, sir. Palpitations
Past 2
generalized.
years. Okay.
Past 2 years.
In between patient was normal. Or
Yes, sir.
what is the status of swelling? Did you mention swelling gradually increase or it has increased suddenly in last few months, year, 2
Yes, sir.
years?
Sir, in the past 8 months, sir, it has rapidly increased, sir. Swelling was small in size initially for past 24 years, sir. Then in the last year, last 8 months, the swelling, the patient complaints
So
of.
have you mentioned that in your history?
Yes, sir. Mentioned, sir.
Go back.
Yes.
Right? Rapid progression of the size. So that is a part of your summary. Swelling since 25 years, which is rapidly increasing since 8 months. Right? So you said palpitation and weakness. What does it mean?
Sir, it is palpitations you see in one of the hyperthyroidism features, sir. Palpitations you get in hyperthyroidism.
On its own?
No, sir. Like in
So what I want to convey is, have you asked other important history which may suggest hyperthyroidism? Because you know what is negative history?
Yes, sir.
What is negative history by definition?
Sir, all the any history like to my diagnosis, like any hyperthyroidism history, like weight loss, or any hypomenorrhea.
Vishwas. Take it easy. Take it easy. Just think before what you are going to talk about. Okay. You have to look. You have got a swelling, which is there for 8 months, and or for 25 years, and increased since last 8 months.
Yes.
Now, what do you think could be the swelling which will give this kind of a history?
Sir, it can be a benign swelling which has turned into malignancy.
So you think it could be malignancy? Now, this is about the pathology.
Yes, sir.
The thyroid has got some function also. So you have to take a history of function. Whether this swelling is it functional or not. So you have to take history of hypothyroidism, right?
Yes, sir. Yes, sir. Taken.
Yeah. So now in your summary, you have to tell us this.
Okay.
And then if you think it's malignant, any history of metastasis.
Yes, sir.
Okay. So summarize now.
So, sir, a 70-year-old lady came with the complaints of swelling in the front of the neck since 25 years. So there is a history of rapid progression since 8 months, and patient had the positive issue of palpitations and generalized weakness. There is no issue of feature suggestive of hypothyroidism, or there is no issue of significant weight loss. So patient is a known case of known hypertensive, sir, since past 2 years, and patient is consuming tablet carbimazole since past 2 years for the same.
Okay. Do you think the dose of carbimazole is okay?
No, sir. Actually, initially we started 10 mg, sir.
Okay. And how is it given?
It is given TID, sir.
Right. So do you think this is right?
No, sir. But the patient is consuming OD dose, sir, as prescribed
Okay.
by.
Okay. That's fine.
Yes.
Vishwas?
Right.
Hello.
Vishwas?
Yes, sir.
Vishwas?
Yes,
You said about the palpitation in 70 years of age, right?
Yes, sir.
That is the main complaint. Why she seek the medical advice?
No, sir. Now she has come here with the swelling, sir, because it is growing a lot, and she wanted surgical opinion, sir. Because previously she was advised there by a doctor in the nearby.
Palpitation at this age is usually surgical cause, or you have to rule out medical also?
Should rule out medical also, sir.
How will you rule out that?
Sir, we'll ask her any generalized fatigue, like in case of anemia, sir.
That is already there.
Yes, sir.
See, at 70 years of age,
Yes.
cardiac condition can also have a palpitation,
Yes.
usually
Yes, sir.
associated with a precordial chest pain. Okay,
Yes, sir.
don't assume that the swelling in front of the neck with palpitation is related with thyroid only. Okay,
Yes, sir.
so think laterally also, little bit.
Yes, sir.
Okay, go ahead.
the point here is that
But
you have
point
taken
that-
a history of palpitation and weakness.
But
What
yes,
I
sir,
wanted
but,
to tell you is, what are the
She-
other history you have asked?
so for palpitation, sir, she doesn't have
Not
like.
for palpitation, because
like-
whenever there is a, you just hear me out, then speak, right?
Yes. Yes.
That is good manners. Just let me finish my question.
Yes.
What I am asking you is, when a patient is having a thyroid with associated complaint, you will ask history related to patient is euthyroid, hyperthyroid, or hypothyroid. So what are the other histories you have asked for a hyperthyroidism?
Sir, weight loss, sir. Hyperthyroidism, any weight loss I have asked, sir.
Oh,
Only
okay.
weight loss?
Palpitation and
Weight loss and heat intolerance, sir.
Pardon?
Heat
So
intolerance, sir.
You mentioned it.
Not mentioned.
That is what I
Same.
was calling negative history. Because the
Yes.
probably patient is on carbimazole, so must be suffering from hyperthyroidism. So you have to ask all the history related to hyperthyroidism, positive as well as negative. The palpitation, there is no weight loss, you have said, and weakness. These two are positive history. What about increased appetite, decreased appetite? What about when patient is female or male?
Female.
Female, sir. Female.
Female. So men's 70 years, so that part is not there. What
Yes.
are the other history you ask? Patient may sometimes complain of tremor also.
Tremor, sir.
Right? The classical feature is increased appetite in spite of there may be a weight loss. So whenever there is a thyroid swelling, history is usually divided into three parts. Do you understand? First is a
Yes.
description of swelling itself. So first you have to describe the swelling which you have. There was a swelling which was initially, now it has increased. You should have more clarified one side, both side, and then it has spread like that. That is the first part. Describe everything about swelling. Whether it has increased rapidly, slowly. If it is increased rapidly, probably it has increased within days or within months. If it is increased in the days, it is probably hemorrhage. If it is in months, it is probably malignancy. Or very slowly, it may be benign. So that is about swelling. Does patient give history of reduction in size of swelling or not? That is also equal important history in a thyroid case. One. Second is the patient is euthyroid, hypothyroid, or hyperthyroid. So you have to ask all history related to that. And third is a pressure symptom. If you divide into these three parts, your history becomes very easy.
Yes.
Okay, continue. Now, so what else you have asked? In summary, you want to say?
Sir, no features of hypothyroidism, sir. I've asked like constipation and no cold intolerance.
Again, that is a pitfall you are falling in. Once you say patient is hyperthyroid, why did you ask history of hypothyroid? Both cannot be present simultaneously.
Yes.
So don't say no history of hypothyroidism, no other significant history. That's all. And why have taken no history of significant? There is no weight loss. That's all.
Yes.
right? But you should always combine with appetite. That is important.
Yes, sir.
What are the causes of weight loss despite of increased appetite or normal appetite?
Sir, hyperthyroidism. In spite of normal appetite, weight loss will be there. And
Anything
even in
else?
malignancies, sir. Malignancies,
No. Weight, the appetite will be, there will not be anorexia, severe anorexia. Causes of weight loss despite of normal appetite or increased appetite. Any other endocrine disease more common than thyroid? Polyphagia, polydipsia, the diabetes.
diabetes.
Yeah. And surgical malabsorption syndrome or shortcut syndrome.
Yes.
Okay.
Yes.
Okay.
Okay, so that is the important point. Sir has asked about carbimazole, right?
Yes, sir.
Okay, since how long patient is taking carbimazole? You have mentioned that.
Yes, sir. Mentioned in treatment
Since
is
how long patient is taking?
2 years, sir.
2 years patient
2
is
years.
taking. So right. So
Yes.
it is same dose since 2 years.
Yes, sir. She's claiming it's the same dose, sir.
Okay.
Same dose. Since
So the associated with that, you should also ask whether the patient has improved after taking treatment or not.
yes. Patient has not improved, sir. Like she has come. Yes, sir.
That you should mention that. That is important. Why patient is probably not improved?
Mostly the dosage of the carbimazole is.
So was patient treated by surgeon or physician? Just also I'm asking.
She doesn't have any. She doesn't give any.
Fine. Sir,
And, that this also gives indirect conclusion that in secondary hyperthyroidism, drugs are not effective.
okay. Shall we continue?
Yes, sir.
Yes.
Okay, go to the examination.
Yes. Sir, a general physical examination. A 70-year-old lady, moderately built and nourished, conscious, cooperative, well-oriented to time, place, and person. So, coming to our vitals, sir. Pulse rate was 72 beats per minute, measured in the right radial artery, regular in rhythm, normal in volume, character, and vessel wall, sir. And blood pressure was 140 by 90 mm of mercury, sir, measured in the right arm, supine position. Respiratory rate was 18 cycles per minute. Temperature measured at the time of examination was 98.6 degree Fahrenheit. No evidence of pallor, icterus, cyanosis, clubbing, and lymphadenopathy or edema. No eye signs related to thyroid, and no tongue fasciculations noted. No tremors. Local examination, sir. Patient is examined in a sitting position after taking consent under adequate light exposure and privacy. So this is the thyroid swelling, sir, of the patient. So inspection, sir. Inspection swelling is present over the anterior aspect of neck involving the right lobe, isthmus, and left lobe of thyroid. Extent vertically on the right side, sir. It is extending, upper border extends approximately up 2 centimeters above the thyroid cartilage, and lower border 0.5 centimeters above the sternoclavicular joints. And in the midline, the extent of the swelling on the upper border it's 6 centimeters from the sternal notch, and lower border is 0.5 centimeters from the sternal notch. Left side, left lobe, vertical extent is at the level of thyroid cartilage upper border, sir. Lower border is 0.5 centimeter from the left sternoclavicular joint. Horizontally, it is extending from the posterior border of one sternocleidomastoid to the posterior border of the other sternocleidomastoid. And movement of the swelling with the deglutition could not be appreciated. Lower border of the swelling is visible. Surface is nodular. Skin over the swelling is normal. Trachea is not visualized. No dilated veins, scars or sinuses. There's a video, sir. Can I play it, sir? Of the deglutition.
Forget it if it is difficult.
Oh, okay, sir.
Forget it, no problem.
Yes.
Go back to your slide, the examination part.
Yes.
Do complete sharing.
Yes.
We are unable to see.
Share
Yes.
your slide. Full screen कर दो. Okay. Local examination.
You are on palpation. Go to that slide.
Palpations. Yes. So is it visible, sir? Yes.
The same slide is visible.
Yes, sir. Sir, is it visible, sir? Palpation. Yes.
You
So
are good to go,
palpation.
Kumar. We are able to see your slides.
Yes, sir.
Yes.
Shall I proceed, sir?
Yes.
Palpation, there is no local rise of temperature, sir. And the swelling is non-tender. All inspector findings are confirmed. And extent same as the inspector findings, sir.
Okay.
Upper border
Next.
extent.
Next.
Yes, sir. Swelling does not move up with the deglutition, sir. Lower border is palpable.
Yes. इससे पहले की slide में जाओ. You have skipped one.
This extends.
So
Same as
I'm sorry to interrupt you. What this 0.5 centimeter and this and that? Is it a routine way to palpate? Don't do this.
yes,
Approximately extension. Does it
Okay.
make if it is 1 centimeter or 0.5 centimeter?
no.
It's okay. Don't go this much. You will not have a time in your exam. That's what I'm
Yes.
trying to tell you. So
Yes.
we generalize it, extend from and compare with only some landmark centimeter, and that is okay. 0.5 centimeter reaches up to sternal notch. How do you differentiate 0.5 centimeter?
Yes.
That it is
More
away.
important point is there is no retrosternal
Retrosternal.
extension. Okay. So
Yes.
better to use that word, that lower border is clearly visible.
Yes.
Right?
Yes.
Okay. Go back again.
Yes.
Yes. The last sentence you have said horizontally extend from posterior border of one sternomastoid to other border, posterior border. Clinically,
Yes.
how it is possible to palpate?
Sir, ask the patient to turn his neck to the other side and make the sternocleidomastoid mastoid thoughts.
What is the normal anatomical covering of the lobes in relation with the sternomastoid?
Sir, it's anterior, sir.
Thyroid is anterior to sternomastoid.
Medial to the sternocleidomastoid, sir. And
What is the relation of lateral lobe of thyroid with the sternomastoid?
sir, it is posterior, sir. Posterior, it is posterior.
Posterior to thyroid gland.
Yes, sir. Like medial and
It covers the lateral surface of the thyroid lobe.
yes, sir.
You cannot palpate the posterior border of sternomastoid.
Yes.
Usually, anatomically, it also goes below, rather underneath the sternomastoid.
Yes.
You can clinically palpate is the anterior border of the sternomastoid, not the posterior border.
Okay.
Okay.
Yes.
Next time.
Let us complete palpation, fatafat, because you are taking too much of time. That's what I'm trying to tell you.
Yes,
Right?
sir.
So that's
Yes.
why I said 0.5 centimeter and this, that is not of much significance. Don't do that.
Okay, sir. Swelling does not move up with the deglutition. Lower border is palpable, sir. Surface is nodular. The largest nodule measures 10 cross 6 centimeters in the right lobe. Consistency is firm. Tracheal rings could not be palpated, sir. And bilateral carotid pulsation is displaced posteriorly, palpable along the posterior border of sternocleidomastoid.
Go further. Next slide.
So percussion, sir. direct percussion over the manubrium sterna is resonant. Resonant note is heard. And on auscultation, no bruit heard over the upper pole of the swelling. Sir. Skull and spine examination is normal. Sir. And systemic examination, sir.
Next.
Cardiovascular system.
Okay. Anything positive in that?
No, sir.
Okay.
Per abdomen also.
This is okay.
So why this is thyroid swelling?
Sir, thyroid swelling, sir, it is a bilateral butterfly-shaped swelling, sir, on the anterior aspect of the neck, which has a significant long history, sir, 25 years. And
Why do you say clinic? What is the characteristic feature of a thyroid swelling?
sir, it is a shape, sir, butterfly shaped swelling, sir.
Shape may not be maintained when the thyroid is such a hugely enlarged. Characteristic feature of thyroid swelling, which always we see in inspection, we always do that in the palpation. You have already done that.
Okay, next.
Sir.
Next slide. Okay. So what should be your diagnosis? First diagnosis.
First time, sir, she is it looks like a multinodular goiter, sir, in hyperthyroid state.
What do you call it? Any other would
Toxic.
like to add on to diagnosis?
Toxic multinodular.
Multinodular toxic goiter. Anything else you want to add? Other thing?
Multinodular toxic goiter in.
No, that's fine. Secondary hyperthyroidism. Is it a right diagnosis or no?
Yes, sir.
Can you call it secondary hyperthyroidism?
Yes, sir.
How? Why?
Because of huge single swellings.
So in other words, let me ask you,
Yes.
why do you put a diagnosis of secondary hyperthyroidism in this patient? Because that should be your diagnosis. I agree, multinodular goiter in hyperthyroid state, you call it secondary hyperthyroidism. Why?
Because sir, first swelling has appeared, sir.
Very good.
Then the patient is complaining of symptoms, sir.
So why complaint have developed now after 24 years?
Sir, because of she was in a euthyroid state, the hyperplasia of the follicles.
So why she has, in otherwise, she has gone in hyperthyroid state?
Sir, maybe conversion of the benign swelling into malignant.
Do not confuse hyperthyroidism with malignancy.
Yes.
Okay, we'll come to that. Why
Yes.
did you put this diagnosis of lymphoma?
Sir, swelling does not move with the deglutition, sir. So it was.
So what may be the reason for not moving with deglutition?
Sir, huge thyroid swelling also doesn't move with deglutition, sir.
Okay, that itself is that. Any other reason?
Malignancy, sir, infiltration.
Infiltration of malignancy. Anything else?
Sir.
The
Riddle's thyroiditis, sir.
No, don't go that anaplastic riddles. That doesn't look like this. It's a
Yes.
totally different phenomena. It's a multinodular goiter. So even anaplastic carcinoma is not a diagnosis in this
Yes.
case. It will be smooth, very hard, not such a large tumor. So the diagnosis will be multinodular goiter with secondary hyperthyroidism or multinodular goiter with malignant conversion.
Yes.
You understand? Those are the two diagnoses. You will keep lymphoma or the anaplastic is not the part of that. Okay.
Yes.
So why the question again comes to that? Why it has become hyperthyroid? What may be the reason? How does any euthyroid status patient develops hyperthyroidism? Let us ask me differently. What is difference between how the patient of primary hyperthyroidism will present?
Symptoms are first, sir. So without the swelling, patient presents with symptoms. So she'll be diagnosed by investigations.
No. It is again a clinical diagnosis, never investigation. swelling may appear later or both simultaneously.
Yes.
What will be the age of the patient usually if primary hyperthyroidism?
Primary hyperthyroidism, young age, sir. In
What
younger
age?
age group,
Yeah.
around yes, sir, around 20 to 30 years, second to third decade.
Second or third decade, predominantly female. 8:1
Yes.
female ratio is there. Now it is slightly decreasing, but it is there, right?
Yes, sir.
In other words, what is the cause of primary hyperthyroidism? Why primary hyperthyroidism develop?
Sir, because of increase in TSH secretion, pituitary adenomas.
TSH is secreted from
Sir, pituitary.
so that adenoma develops. You want to say? Just
Sir, it can be engage, sir. Engage. It can be autoimmune conditions.
yes.
I would
that's
like to
the
intervene.
autoimmune, right?
I would like to intervene.
Yeah, please, sir.
I am Dr. Vidyadhar Kinnal from Bellary.
Yes,
I
sir.
have joined late because I was in OT all this time. Just now I'm come out of the OT and then trying to report back. TSH increase suggests what? You are
Yes, sir.
discussing
I
about
got-
thyrotoxicosis.
Yes, sir. Sir.
Sir. Vishwas,
Yes.
you are discussing about primary thyrotoxicosis.
Yes, sir. Yes, sir.
And you say TSH
Yes,
increase
sir.
suggests hypothyroidism, not hyperthyroidism.
Yes.
The demand of thyroxine has increased in hypothyroidism. That is why you find the TSH being more. How can you correlate both? Though they will not coexist. Sir, good morning, sir. Kanagvelu, sir. I'm sorry, I was in OT, sir.
Sir, no problem, sir. Yeah, they said your junior called up to tell you are in a surgery.
Yeah.
Thank you, sir. Thanks for joining.
I'm extremely sorry, sir. I'm delayed before.
No problem, sir. No problem. Perfectly understood, sir. Please carry on.
Now, Vishwas, you tell me. My friend was asking, another boss was asking you that the reason for primary thyrotoxicosis is what? You were telling something?
Sir, autoimmune conditions, sir.
Autoimmune conditions, what is thyrotoxic fixatia? Autoimmune conditions does what? It kills thyroid tissue. It doesn't generate thyroid tissue. So it will rupture the thyroid cells so that the thyroxine enters temporarily into the circulation. They go into a early thyrotoxicosis for a very short period. That is not hyperthyroidism. It is called as thyrotoxicosis fixatia. You are which year PG, Vishwas? Let me know.
First year, sir.
First. Okay. You have a long way to go. Doesn't matter. But autoimmune disease and thyrotoxicosis usually do not coexist. Usually. Very rarely it happens. But you want to tell me Hashimoto's thyroiditis will have hyperthyroidism? Lymphoma of thyroid will have hyperthyroidism? I don't think so. I'm sorry, I'm entered in between because what are the primary presentation, other things are not known to me. However, TSH increase will suggest that there is hypothyroidism, not hyperthyroidism. Yes, continue.
Okay.
No, where you have left, you start from there. Pankaj Modi.
Yes, sir. Yes, sir. I was okay. So the primary is usually autoimmune. The why it is autoimmune, it is not related to TSH level. Understand this. Sir must have explained it. So understand that it is because of nothing to do with TSH. You understand? It is because of the thyroid secreting antibody or TSH, thyroid stimulating antibody, which causes the direct defense of thyroid bypassing the TSH. That is primary. So younger patient in normal thyroid, that TSAB starts and ultimately patient starts having hyperfunction, which causes secondary hypertrophy of thyroid. The swelling will appear little later. That is right. It also affects on the eye, peripheral myxedema, exophthalmos. These are the features of primary hyperthyroidism. Now the question is, what about secondary hyperthyroidism?
Sir, secondary hyperthyroidism, sir, patient will have the palpitation, sir.
No, palpitation can be present in both, more pronounced in a secondary. The reason is usually secondary occurs in an older patient. Cardiac condition is already weak, so palpitation is more. And in primary, because of the stress factor, neurological symptoms will be more easily, right? But the secondary hyperthyroidism develop is a patient having existing thyroid, which convert first into multinodular goiter, right? Till the patient is euthyroid. In a long-standing multinodular goiter, the patient, one of the nodules may escape from control of negative feedback and start secreting thyroid hormone on its own. So in spite of low level of TSH, thyroid goes on functioning, that nodule. And then it is considered as hyperthyroid state. And because it has developed in existing thyroid swelling, and that's why it is known as a secondary hyperthyroidism. Here the reason is nodule itself. So patient does not have an exophthalmos. Patient does not have a pretibial myxedema. Stress factor will not be there. But as the thyroid acts on the receptors, that is sympathetic receptor, on a heart, it will have effect, and eye signs will be present only in a form of lead leg and lead spasm, which is
Vishwas, we have multiple nodules in the thyroid, multinodular goiter. Is it not? That's what you have described, multinodular goiter. What part of the gland will be secreting the hormone?
The normal parts, not the nodule.
It is called as what? Internodular tissue will be
Internodule.
Yeah.
Yes.
What will the nodule contain?
So it contains inactive thyroid.
Necrotic thyroid material. Necrotic thyroid material. Why does it happen so? Why does it happen so? The nodule becomes. How do you make out that it is necrotic tissue or it is a living tissue? How do you make out that the nodule that you're feeling is a necrotic tissue or a living tissue? It is made up of.
Necrotic tissue will be like soft in consistency, sir.
ऐसा तो नहीं हो सकता. No, that cannot. See, if at all, necrotic tissue is there, you do a Doppler, what will happen?
Sir, no blood flow, sir.
If it is living tissue,
the blood flow.
So, Professor Pankaj Modi was telling that one of the nodule becomes hyperactive. That is called
sir, I would like to differ. We don't call it necrotic tissue, sir. It's a colloid material inside.
That is
not
for
a necrotic material, because if it is a multinodular goiter, which is benign, and it is a colloid in nature, so it is not a neoplastic. So it is not a necrotic, but
definitely not neoplastic. Multinodularity, hypothyroidism. If there is a colloid, that is called as hypothyroidism. If it is hyperthyroidism, internodular tissue is functioning more than the nodule. Yeah. What is a cold nodule becomes a hot nodule. See, a cold nodule, it is not picking up the iodine that you have given. It becomes a hot nodule because it has got a functioning tissue within it. So there is a different, one nodule hyperactive, it is called as autonomous nodule. A multinodular goiter thyrotoxic, it will have most of the tissue, internodular tissue will be secreting hormone, unlike the multinodularity, which will not be secreting. That is what, and may not be necrotic, but ischemic tissue it will be. Because it will not, you do a Doppler, you will be able to see the vascular supply within the nodule. If it is you have any difference of opinion, sir? Pankaj Modi, sir?
No, sir. I am agreeing. Fine. There are 2 or 3 points I would like to, because I think that he is not well prepared, because I can understand he's a first-year resident. I sympathize with him. The point here, and that this is not a simple subject. What I want to say is the multinodular goiter, there are 2 types of presentation. One is the nodule, more than one nodule, as sir has said, may be functioning or hyperfunctioning, giving typical feature multinodular toxic goiter. Sometimes in early only one nodule becomes, then you call autonomous toxic nodule or solitary toxic nodule. Other, because of the early function of one nodule, it will suppress the other function of other nodule as a tissue. So these both are part of multinodular hyperthyroid state, divided into multinodular goiter and a solitary toxic nodule. There is a one internodular tissue. In a rare of the circumstances, the nodule remains benign, internodular tissue becomes hyperactive. That is what his books have described as a Graves' disease in a multinodular goiter, but we'll not go in detail of that. So these are the 2 parts. I absolutely agree with you. The problem here is the patient really hyperthyroid in this patient?
No, sir. But clinically, symptoms are not so much like.
So the reason is patient is under medication. You can argue.
Yes,
but
sir.
So that medication will cause this much of regression of symptoms.
I have one small clarification to be sought from him. Graves' disease is called for what? Secondary thyrotoxicosis or primary thyrotoxicosis?
Primary.
Yeah. Go ahead. Go ahead, sir. I was asking something.
The question was that, so is the patient really hyperthyroid? What is the pulse rate of patient?
Sir, pulse rate of patient 72 beats per minute, sir.
72 beats per minute. And only actual symptom is palpitation. As Ashish sir has said, it might be heart condition of patient itself. Do you understand?
Yes, sir.
So is the patient hyperthyroid, or so differential diagnosis should have been one diagnosis, that is multinodular euthyroid or multinodular hyperthyroid. Both can be there. It is a possibility. So the 5 milligram of carbimazole will not resolve the symptoms as a whole. So that should be kept in a mind. Do you understand? Okay.
Yes.
Okay.
So now
and-
these are, yes, sir.
Sir, please continue.
No.
I just asking you the provisional diagnosis, the lymphoma and anaplastic, they are a histopathological diagnosis. So don't put that diagnosis.
Yes.
Yes, sir.
So
Agreed.
clinical diagnosis that Dr. Modi sir said, ki multinodular, and second, the
Either euthyroid or hyperthyroid. Both can be diagnosed.
I beg to differ. A
Yes,
single slide should not contain a hyperthyroid state and an anaplastic carcinoma. How many carcinomas you have seen it as a hyperplastic? But they will
Exactly.
not
That's
go
what
hand
we
in hand.
already said, sir.
They will not go hand in hand. If it is
Nodular,
hyperthyroid,
it is not there.
yeah, if it is hyperthyroid, most of the times the malignancy is ruled out. If it is, there is no euthyroid state, yes, you can. But this first point and last point do not go together. Okay.
Because that was a very well taken point by Dr. Asit, that palpitation is the only symptom actually patient is having, according to you. And that can, at the 70 year of age, very well can be explained other than hyperthyroid. So
Being the doctor, we can get palpitation. I don't think the
multinodular
present day-
euthyroid or
present day-
multinodular hyperthyroid. You should have put those.
Present day diagnosis is not based only on clinical examination.
Hmm.
However, a palpitation fully will not support the presence of hyperthyroid. Yes,
Yeah.
go ahead.
Yeah. So now that's what I want to see, how you progress or build your case. So you should put a provisional at these two provisional diagnosis, multinodular non-toxic, multinodular toxic. Now, how will you, others are not okay. Or third remote possibility, if you at all want to put, is a conversion to malignancy. That is another point itself.
Yes.
Right? So now how will you progress, proceed in this case?
Sir, investigation, sir. Blood investigations. We can send one thyroid function test, sir, with free T3, free T4, and TSH, sir. So we have done our thyroid function test, which has come as T3 as 119 nanogram per deciliter, and T4 as 5.84 micrograms per deciliter.
So are they normal or higher?
Normal, sir.
They are normal.
Normal, sir.
One sentence you should add. They are normal with treatment or without treatment. Easy on a treatment.
Yes.
She is on treatment with carbimazole 5 mg, sir.
An hypertensive with normal reading, you cannot brand him as non-hypertensive. He is an anti-hypertensive.
Anti-hypertensive.
Today you are regarding his blood pressure being normal. You cannot brand him as normotensive. Now, similarly, T3, T4, TSH are within the normal limits of range, but is he on treatment?
On treatment, yes, sir.
What is he taking?
She's taking carbimazole tablet 5 mg, sir, OD dose.
So that means you should consider that you are controlling somebody. You should have two charts now. What was before the starting of drugs? What was after starting the drugs?
Before
Why did the carbimazole was started unless there is increase in T3 or T4? Is it not?
yes, sir.
Why did they start anti-thyroid drug?
Sir, the previous report she didn't have, sir. 2 years back. She was,
Fantastic. She is taking neomercazole since 2 years.
2 years, sir.
My God. ठीक है. Magar, this is within the normal limit range of all the investigations you are showing. However, are you sure that she is taking carbimazole?
Yes, sir. She's taking, sir. Yes, sir.
Okay, go ahead. We'll see. Subsequently, you
Right
have
from
got
the
answer
same
also.
dose she has taken.
She's taking, yes, sir. Same dose, sir.
Same dose.
Same dose.
What is the
risk?
maintenance dose of carbimazole?
Sir, at 10 mg. 10
What is
10
the risk,
mg
man?
total?
Total per day 30 mg per day. 10 mg
Okay.
T8.
So second question, she is taking only carbimazole or any other drug?
No, sir. Only carbimazole.
So which other drug is commonly given?
Methimazole, sir. Methimazole.
No. Methimazole, carbimazole, this mazole all are one group.
Yes, sir. Propylthiouracil.
Are?
Same group. It's all anti-thyroid drug.
Imidazole
Which-
group of drugs. They are
Have
called
you
as
seen a
imidazole-
patient being treated?
They are called as imidazole group of drugs. Yes, go ahead.
For palpitations, sir, beta blockers.
You find something there written 2D echo and then written something else, you would like to continue with that beta blocker? What is the problem of beta blocker? What does beta blocker do? You name one beta blocker.
Sir, propranolol, carvedil.
So what is the dosage and what do you how drug dosage duration? That should be posology. What is posology? Study of a drug dosage duration. 3D. You must. Drug is propranolol. Dosage. Dosage. Whenever you come name a drug, you must know about its dosage as well as duration.
Yes, sir.
What
40
is the
mg.
dosage?
40 mg. 40 mg, sir. 40 mg.
Would you like to give it here? 2D echo shows mild LV and then good LV function.
Okay.
And has she got a history of bronchial asthma?
No, sir. No bronchial asthma.
Okay. So she has been on carbimazole for last 2 years. These are the investigations that you are projecting now. Okay.
Yes.
How do you proceed?
Sir, I would like to ask him 1 or 2 questions.
Yeah, sure. Please. Sir.
What is the action of carbimazole? Let us clarify.
Fine.
Sir, carbimazole, sir, it acts on TPO, sir, thyroid peroxide oxidase enzyme. It inhibits it, sir. So,
So, what are the drugs acts at the different level? What are the levels where the drug acts? The first group acts in the trapping that prevent the iodine to come in thyroid. Second is dehalogenase and peroxidase, conversion of iodide to iodine. And third is MIT-DIT, right? And fourth is a thyroid is brought out. And the fifth level it acts is on the target itself, where the receptor acting. So each level different drug acts. Fantastic. So where does the carbimazole acts?
At synthesis, sir. Synthesis of the thyroid hormones.
Yes, peroxidase and dehalogenase. The goitrogen drug acts in the trapping, right?
Yes, sir.
Like PAS and that. And extraction means the removal of thyroid from that is prevented by one drug, that is lugolsiodine, which compete with the binding endpoint. And the fifth group is on target organ. So which drug acts on the target? It's a very simple question. It is in continuation of the questions we have asked. Sir has asked about bronchial asthma. So,
a target
beta blockers.
Beta blockers.
So it blocks the action of thyroxine at the receptor level.
T3.
You understand? So the beta blocker has two main problems. One, it can cause the heart block and then cause bronchial spasm because it block the receptor for that. That's why
functioning hormone is T3, sir, not T4. So it blocks the entry of T3. Propranolol blocks that receptor so that T3 cannot. T4 is in circulation, gets converted into T3 before getting entry into your cell. Okay,
exactly. Fine. Okay, so that should be kept. So propranolol is given for a combination with carbimazole for two reasons. One, for a target organ, and secondly, to decrease the combined dose. If you give only one drug, you'll have to give higher dose. If you give both drugs, it can be supplemented. It also supposedly prevent the conversion of T4 to T3, which is active ingredient. Please continue, sir.
Yes. So, sir, another relevant investigations, USG of the neck can be done, sir, ultrasonography. But for this patient,
there is Vishwas, there is nothing like can be. What you will do?
Yes, sir. You ultrasound of the neck, sir, to be done, sir.
So, will you do X-ray first or ultrasound first?
X-ray, sir. X-ray.
X-ray. Why will you do X-ray? AP and lateral?
Sir, to look for any tracheal compression, sir. AP, look for any tracheal deviation. Laterally, we can look for any tracheal compressions.
Okay. What else you will look in X-ray?
Sir, spine, cervical spine.
No. In thyroid, can you see anything else?
See, Vishwas, we keep on primary principles of reading an X-ray. You must do a skeletal survey. You must do a soft tissue survey. You must do a luminar structure survey or luminar structure containing air and soft tissue survey in the subcutaneous region. So that when you mention these in these orders, skeletal survey, you will not be missing anything. See, he was asking about spines. He was asking about trachea. Now you will also be able to see so many other structures. They are called as soft tissues. Is it not? Even subcutaneous soft tissue can also, nowadays digital X-ray has come. You will have fantastic clarity about the X-ray and you can definitely interpret a lot of things in a neck X-ray. Okay. So you do, forget about neck X-ray, chest X-ray, read skeletal survey, like that 4 stages you read a plain X-ray, you will be able to appreciate better and you will not be missing anything. Okay, go ahead.
Yes, then ultrasonography of the neck.
So
What
why
ultras-
will you do ultrasonography?
Sir,
So in
sir,
X-ray, I wanted to add one more thing, that is a calcification can be
Yeah.
seen. That is why sir was saying, hinting that soft tissue. So it's always should be mentioned that whenever you take a plain X-ray in thyroid case, calcification has type of calcification, because some malignancy do present as a part of calcification known as a samoma body, in particularly papillary seed can, or even a massive calcification in a multinodular goiter. So always soft tissue survey is also important. Now, why will you do USG?
So ultrasonography to look for any the nodules, sir, whether it's a cystic or hard nodule, or any lymph nodes, any lymph node in the neck, sir, enlargement of any lymph nodes in the leg. And
Why? What is the ultrasound transducer you use? 3.5 megahertz, 6 megahertz, 7.5 megahertz, a convertible transducer, because the transducer nowadays ultrasound, they also can be holding in the hand, it can be made into a Doppler transducer. Now you have to say that it is just 1 centimeter beneath the skin, and whatever abdominal ultrasound you are doing, it will be with 3.5 megahertz. Will you be able to see something in the thyroid? No, it should be on the higher megahertz, not less than 6, or most of the times we use a flat transducer that is called a 10 megahertz probe. And in this, please don't buy out that ultrasound says solid or cystic. No, man, ultrasound gives everything. Sometimes it is better than CT.
Yeah.
Sometimes it is better than CT.
Even
be
the
able to see
thyroid
the-
classification is based on sonography.
Yeah,
Entire
You know that
thyroid.
what is thyroid classification?
sir, thyroid's classification, thyroid's 1, sir. It is a non neoplastic, sir. Thyroid's 2 is benign. Thyroid 2 is benign, sir. Thyroid 3 suspicious of malignancy. Thyroid 4 is divided into 4A and 4B and thyroid 5. 4A is lower suspicion of malignancy. 4B and 5 is higher suspicion of malignancy, and there are 4 points in higher suspicion of malignancy.
Okay.
There are hyper echogenicity seen, one point, and microcalcifications, and taller
Taller than broader.
Taller than
Yes,
wider.
Very
taller
good.
than
Yeah.
broader.
good.
So if it's 5, sir, if it's a thyroid 5 means more than 3 should be positive, sir. Thyroid
Right.
4 means
What
more
about
than,
capsule and papillae? And vascularity. These are the various points you should, because that, as sir has said, the ultrasound shows marvelously, everything is seen there, right?
yes.
You make it black and white as well as color. See, you will be able to see carotid arteries. You will be able to see intrajugular vein. You will be able to see superior thyroid artery, inferior thyroid artery, everything that is including the sternomastoid muscles, strap muscles, cricothyroid. So many things are described under one ultrasound with minimum 6.5 megahertz probe. You'll be able to do a fantastic work. Go and read more about thyroid. Nowadays, know more about ultrasound, because ultrasound is a part of MS General Surgery curriculum now. Every postgraduate student should know how to handle a ultrasound equipment, and it will be a bedside. And MCA has already put in that all PGs, MS General Surgery PGs should know how to do an ultrasound. Especially, do ultrasound in the emergency ward. It is called as what? Forget about it. Now it is not connected to this. Fine, go ahead.
Yes.
Okay. So yes, ultrasonography is a thyroid function test, plain X-ray, ultrasonography. Next.
Sir, fine needle aspiration can be done, sir.
What I am telling you,
Okay,
you are
sorry.
in exam, nothing like can be.
Fine needle aspiration.
So many things.
We are asking you what you want to do. There is nothing
Fine
like
needle
can here.
Fine needle aspiration cytology.
You would like
you
to
will
do? First thing is, would you like to do?
Ultrasonography guided FNS is
From where? From where?
from the nodules. From
Which
the
Both sides there are nodules.
in this patient, there was an largest nodule measuring 10 cross 6 centimeters. That dominant nodule we can take from the dominant nodule.
Actually, I would like to pick up a nodule which has got internal solid echo as well as cystic echo, so that the floating tissue you will be able, under ultrasound guided, you can touch that nodule which has got solid as well as cystic areas in that nodule. I will be able to get good sample through that. Ultrasound guided aspiration is best methodology of diagnosis nowadays, which they earlier used to say that don't do, but it can be done. And you have chosen it nicely. Yes, you can do an ultrasound carried aspiration and for FNAC. Okay. Yes.
What are the points against doing FNAC in multinodular?
Sir,
Yes, sir has point. That's why I pick up that question. Some believe that you need not do it. That's what I am trying to tell.
in FNAC, sir, FNAC is not conclusive for that follicular carcinoma of thyroid. Sir. We can proceed with
No,
FNAC.
you are not getting my point. That is for any solitary. I am saying multinodular goiter. Is it worthwhile to do FNAC from any specific suspicious nodule or more than one nodule? That's the question.
Sir, more
Sir,
than
would
one.
you like to say anything? Vidyadhar sir?
Yes, sir.
Ah.
See, the earlier description, what they used to do was FNAC may cause the track that it goes in, it may attract some malignant cells along the track that we have pushed in. That was one of the reasons why they never used to. And some of the times, if it is he's not euthyroid, he may go into a thyrotoxic crisis. It should be done. That's what they used to teach us during my time. As of now, FNAC for any thyroid, whether it is euthyroid or multinodular or huge thyroid, as of now, there is no direct contraindication for FNAC under ultrasound carried aspiration.
Yes. The question, you should always say FNAC under ultrasonography guidance. You understand? As such, there is no role of blind. And what I wanted to say, multinodular goiter, there are many nodules. Unless there is a one specific suspicious nodules, there is no purpose of doing no FNAC from all nodules, right? Because ultimately the treat will come to that treatment. Okay, so FNAC will do ultrasonography if required, particularly if there is a suspicious of that, right? The disadvantage you were saying something about FNAC has a.
Sir, in follicular carcinoma of thyroid, sir, we can't
So
differentiate.
which malignancy is more common in secondary hyperthyroidism?
Follicular.
So
Follicular.
there is no role of FNAC then.
FNAC, sir.
Because that is more likely to be pathology.
Fantastic question. He should have analyzed it much earlier before describing so much. Sir, I am suspecting follicular. FNAC will not yield anything. What shall I do? It's what Vishwas, what do you say? Patel sir is asking you a relevant question.
Yes, sir. Sorry, FNAC was.
FNAC was mentioned earlier. Now it is condemned. You're not supposed to do FNAC now. It is removed from the recent textbook as well as journals. FNAC is a term not to be used. Okay, go ahead.
Okay.
Sir, CCT head, neck, and thorax, and CCT abdomen and pelvis can be done.
All of them for what?
Sir, for a CCT
Fetches
abdomen.
you money.
No, sir. If you're suspecting any malignancy, sir, like in abdomen and pelvis, you can look for splenomegaly or hepatomegaly, sir.
We have got a message from the administrator. We are left with 8 minutes. You tell me what is the diagnosis that you are suspecting. After discussing so much, what is your diagnosis?
Sir, multinodular goiter in hyperthyroid state, sir.
Why do you say hyperthyroid, man?
No, sir, since the patient is on treatment.
Vishwas, he is on euthyroid. Because the patient is euthyroid, you have given all the reports that the T3, T4, TSH, all of them are within normal range.
Yes, sir.
See, you must say that you must say multinodular goiter under antithyroidics in euthyroid state.
Yes.
That should be the, is it not?
Yes, sir.
What do you want to do now? 2
sir,
years now. It's very important because antithyroid drug given for 2 years itself is dangerous.
Yes.
Yes,
granulocytosis they will go into.
Yes, sir. So you plan for total thyroidectomy, sir.
You plan. You don't ask me to plan. What do you do?
I'll plan for a total thyroidectomy, sir.
Why?
Sir, because a huge.
See, hyperthyroidism and malignancies most of the times do not go hand in hand. You would like to do a total thyroidectomy?
Yes, sir.
Why?
Sir, because of the huge swelling, sir. Huge gland swelling, sudden increase in size, and but we're waiting for a report, sir. If
waiting for what report? FNAC report.
FNAC reports and
FNAC is not going to helpful in managing this case at least.
So you'd like to do a total thyroidectomy?
Yes, sir.
But substantiate that. Why do you want to do a total thyroidectomy?
Justify.
Will you, after thyroidectomy, what will you do for the patient? Remaining part of his life or her life?
Supplement with levothyroxine tablets. Thyroxine.
Throughout life.
Yes.
Why you want to do that?
Sir, there is no thyroid hormone, sir, after the removal of the supplementation with thyroid hormones.
You have
It's
done
not
well.
replacement. Suppression.
You have done well considering you as first year postgraduate student.
Yes, sir.
There are a lot of areas to be covered.
Yes.
Because how many thyroids you have assisted so far?
Sir, 4, sir.
4. Okay. There is a lot of scope for you to implement. I would say, Vishwas, you have
Yes,
a good future.
Yes,
Study
sir.
well, come out
Yes.
with successfully, and then
Yes.
also serve our society as a surgeon. Good
Yes.
luck to you.
Thank you, sir.
Dr. Vishwas, thanks for joining us today. Do you have any doubts or any questions you can clarify with the national faculty here?
No, sir.
Thank you very much. And
Thank you, sir.
give our thanks to and regards to Professor SRB, sir.
Yes, sir.
So we look forward for you to have on sometime very
Sir,
soon.
can I say something?
Please, sir,
Sorry,
please, sir.
Because emergency call. The one thing is that he need to work on his history taking first. What I wanted to say is that he's still in an undergraduate mode, point by point. It should be a fluent history in a sentences, not like 70 year, this, that. Do you understand? I can
Yes.
understand your first year, it will take time, but that you work on your history, it will be better. And
Yes.
second, what I wanted to say is, this is not a theory seminar. This is
Yes.
exam lecture. Not
Yes.
lecture, I would say exam. So you should say what I will do. You
Yes.
don't give me the list. List is not needed. What you say, sir, first I will investigate patient to decide state of euthyroid or not. Followed by I will go for ultrasonography and if required FNAC as per. Accordingly, you do not mention CECT is required or not, that you will decide. You do not
Yes.
give the list. Do you understand?
Yes, sir.
Let the examiner ask, no, sir, I will do this for this reason or not reason. That's all right. But you have worked. Fine. You tried light. Yes.
Yes.
Okay. Thank you, sir.
Yes, thank you, sir.
Kanekal, sir, I will have to leave because I have got
Yes, sir.
a
Yes, sir. Perfectly understood, sir. Being on call for emergency.
Okay.
Thank you, sir. Thanks for joining in such a short
Yes.
notice.
Yes.
Now, with the permission of the faculty, we move on to the next case. Thank you, Dr. Vishwas. You can stay back
Yes,
for
sir.
the discussion.
Yes, thank you, sir.
I warmly welcome Dr. Madhu. He is from Alamin Medical College, kindly contributed by Professor Nishikant Gujar, sir. And I request Madhu to share his PPT and start his presentation. Please introduce yourself, your unit
evening.
chief and head of the department before starting your presentation. Good luck to you.
Yes. Yes.
Sir, good evening, sir.
Make it into slideshow.
No.
On the right bottom, you can see one screen. Press that.
That's the basket that you are seeing right bottom. Come to the bottom line. There is one volume button. There is one basket there. Press on that. Madhu, are you hearing me?
Yes, sir.
You make
Yes,
it
sir.
slide
Hearing.
show. You make it slide show, Madhu.
Yes, sir. I have done it, sir.
You please
No.
unshare the screen.
Why are we seeing this
Sir,
slides?
one second,
1, 2,
sir.
3,
One
4.
second, sir. I will start that out. Please unshare your screen.
Yes, sir.
Now press share. What are the screens you are
Yes.
seeing? Are you seeing
Sir,
the
Chrome
PowerPoint
tab
window?
window.
Are you seeing the PowerPoint window there? Just press on the PowerPoint.
Yes. Yes, sir. Sir, is it fine,
You are
sir?
not pressing
No.
the right window. Please close your PowerPoint.
Sajid Mudol sir is online.
No, sir. No, sir. Not yet. Sir.
Okay. I know him personally. That's why I asked.
Oh, very good, sir. Very good, sir. You open the PowerPoint.
Yes, sir.
You scan. You just press screen share. Press the share your desktop.
Madhu, ನಿನ್ ಜೊತೆಗೆ ಯಾರಿದ್ದಾರಪ್ಪ? ಇನ್ನೊಬ್ರು ಹೆಲ್ಪ್ ತಗೋ.
Yes, sir. ಇದಾರೆ sir. ಆಯ್ತು.
ಮತ್ ಇನ್ನೊಬ್ರು ಹೆಲ್ಪ್ ತಗೋ. ನೀವು ಪವರ್ ಪಾಯಿಂಟ್ ಸ್ಲೈಡ್ ಶೋ ಮಾಡಿದ್ರೆ ಹೆಂಗ ಕಣೋ? ನೋ. ಇದು ಸೈಡಿಗೆ ಸ್ಲೈಡ್ ಲಿಸ್ಟ್ ಬರ್ತಾ ಇದೆ 1 2 3 4 ಅದು ಬರಬಾರದು.
1 second, sir. 1 second, sir. On the top you have view, no? Home. On the top.
Yes, sir.
No, please do one by one. Don't do in between. When I instruct, please follow the instruction. That saves time. Share your desktop now.
Yes, sir. Yes, sir. Desktop.
Recording in progress. That there is no point giving it zone wise. It is probably this GC is supreme. Just GC can decide who are the people. They can give their suggestions, and then they should not be a restriction.
You minimize this window. You open your PowerPoint.
Yes, sir. Sir, can you see, sir?
I am unable to see. You take somebody's help if you find difficult.
Yes, sir.
You please unshare now. You open your PowerPoint.
Yes, sir. Open, sir.
Press share, screen share, and touch the PowerPoint.
Green color. Share screen. Share screen ಮಾಡ್ದ. ಅದು PowerPoint share ಮಾಡ್ದ.
Are you with us, Dr. Madhu?
Yes, sir. Yes, sir.
Please follow the steps I am telling.
Bandwidth is very low.
Sir, is it?
Very low.
Okay, you make it into on the top. You can see. Why are you unsharing, Madhu?
ಮಧು ನಿನ್ ಜೊತೆಗೆ ಯಾರಿದ್ದಾರೆ ರೂಮ್ ಅಲ್ಲಿ? ಮಧು
ಇದೆ ಫ್ರೆಂಡ್ ಇದೆ.
ಕರಿ ನಿನ್ ಬರ್ತಾ ಇಲ್ಲ ಅದು. ನಿನ್ ಬ್ಯಾಂಡ್ ಬಿಡ್ತು ಬಹಳ ಲೋ ಇದೆಯಲ್ಲ, ಯಾಕೆ? ವೈಫೈ ಇಲ್ವಾ ರೂಮ್ ಅಲ್ಲಿ?
ಇದೆ ಸರ್, ಇದೆ.
ಮತ್ತೆ ಯಾಕೆ ಇಷ್ಟು ಬ್ಯಾಂಡ್ ಬಿಡ್ತು ಲೋ ಅಂತ ಬರ್ತಾ ಇದೆ?
ಸರ್ ಬರ್ತಾ ಇದೆಯಾ ಸರ್? Is it coming, sir?
Will you listen to my instructions?
Yes, sir.
There is something called slideshow on the top left. Can you see? Come to the left top. There is home.
Yes, sir.
And fourth, there is one thing called slideshow.
Yes, sir.
Please, from beginning on the left side, press that.
Yes, sir. Is it coming, sir?
making everybody's life miserable. Okay, you present like that.
Sir,
Go
from
one after
beginning.
slide. You keep presenting.
ಅಲ್ಲಪ್ಪ ಸ್ಲೈಡ್ಸ್ ಮಾಡು ಮಾರಾಯ, ಕೆಳಗಡೆ ಒಂದು ಇದೆಯಲ್ಲ ಇಲ್ಲಿ.
Sir, I think he is not sharing the right window and he is going into the wrong window, sir. Let us start his presentation, sir.
Yeah, go ahead, man.
I understand the challenge of presenting like this, but I think we are not able to rectify him, sir. So let him start his presentation, sir. Start your presentation, Dr. Madhu.
Yes, sir. Sir, my name is Dr. Madhusudan, sir, second year junior resident from Department of General Surgery, Alamin, sir. Under the guidance of Dr. Nishikant Gujar, sir, my professor and guide, Department of General Surgery, Alamin. My HOD is Dr. Sajid Mudol, sir, Professor HOD and General Surgery, Alamin Medical College, sir.
Bijapur, you say that, Bijapur.
Sir, here is the patient of age 32 years by name XYZ, resident of
You have to
Bijapur,
change your
who is
slide,
a
Kana.
bank employee.
Come to second
Please
slide.
change your slide.
Madhu, come to second slide. Press forward button from on your laptop.
Yes, sir.
ಬಂದಿಲ್ಲಲ್ಲ ಮತ್ತೆ.
Sir, network issue. Sir, network issue.
ಲೇ ನಮಗೆ
Sir,
ನೀನು
there is some
ಹೇಳ್ಕೊಡ್ಬೇಕು,
network
ನಿಮಗೆ ನಾನಲ್ಲ.
Sir, you didn't pick the call in this.
Sir, shall I present, sir?
ಸ್ಲೈಡ್ ಚೇಂಜ್ ಮಾಡಿದ್ರೆ ಪ್ರೆಸೆಂಟ್ ಮಾಡಬಹುದು. ಅದೇ ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ ನಿಶಿಕಾಂತ್ ಗುಜಾರ್ ಅಂತ ಇಟ್ಕೊಂಡ್ರೆ ಏನ್ ನೋಡ್ಬೇಕು ನಾವು? ವಾಟ್ ಶುಡ್ ಐ ಸಿ ದೇರ್? The first slide is being shown there. Now what about the second slide? Come to second slide. Click on second slide at least.
Come, go on to the second slide. Your cursor, bring that cursor to the second slide.
You can press the forward button also.
Yeah, anything.
The second slide.
You have not done a mock show before presenting here?
Yes, sir. I have done it, sir.
But ಮಾಡಯ್ಯ, ಮುಂದೆ ಒತ್ತಯ್ಯ, ಮುಂದೆ forward button
Please
ಒತ್ತು.
answer your PowerPoint, Dr. Madhu. Vishwas? Dr. Vishwas?
He is from Mangalore, no? Vishwas is from Mangalore, is it?
Yes, sir. No, sir. I have shared the PowerPoint. I think we have to keep going with the class. I don't know.
Shall I present, sir?
ಏನ್ ಬಂದೇ ಇಲ್ಲ, ಹೆಂಗ್ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತೀವಿ? ಹಿಸ್ಟ್ರಿ ಹೇಳೋದು ಬೇಡವಾ ನಮ್ಗೆ? ಇಲ್ಲಿ ಸ್ಲೈಡ್ ಬರ್ಬೇಕಲ್ಲ ಮೇಲೆ. ಐ ಆಮ್ ನಾಟ್ ಏಬಲ್ ಟು ಸಿ ಯುವರ್ ಸೆಕೆಂಡ್ ಸ್ಲೈಡ್, ಮ್ಯಾನ್. ಹೌ ಕ್ಯಾನ್ ಯು ಪ್ರೆಸೆಂಟ್?
Hey, you may be remembering the finding. We have to go to the many times, go to the other slide and come back. Without PowerPoint presentation, it is
So
not.
can he mail it to someone and someone else can do it for him?
Yes, that can be done. Yes, Madhu, can you mail some?
Yes, sir. Can I
Sir,
stop share, sir?
I have informed. Please unshare your PowerPoint, Madhu.
Yes, sir.
I have informed and requested Dr. Vishwas to share the PPT. But I think you should spend time rectifying your problem.
Yes,
Because
sir.
this is a common thing. Everybody should be aware of doing things. So if you have a problem with your system, please reinstall or do something.
What I have said that I have found out.
Please stop your PPT, stop your audio. Vishwas, are you with us?
उनको स्टार्ट करने के लिए
आप क्यों नहीं बोले मेरे को? ये क्यों नहीं इन्फॉर्मेशन दी है? नहीं, दूसरा काम तो हमें करने करेक्ट आता है। नहीं, आपको दूसरा काम करना करेक्ट आता है।
Dr. Vishwas?
Yes, sir. Yes, sir. Getting it done, sir.
I'm sorry.
Yes, sir. Give me 2 minutes. I'll get it.
Yeah.
Hello?
Yes, Dr. Vishwas.
Yes, sir. Getting it done, sir. 2 minutes.
Yeah, okay. I request you to stay with us, Vishwas. As he
Yes.
advances the slide, you can help him to do it.
Yes, sir. Yes, sir. No problem, sir. I'll share it. I think.
Yes, Dr.
Sir, can
Vishwas. Yeah.
Sir,
We are just make it full screen, Vishwas.
yes, sir.
You can advance the slides as he presents, Dr. Vishwas.
Yes, sir. 1 second. Sir, is it fine, sir?
Yes, perfect. Thank you very much.
Yes, sir. I'll advance, sir.
Yes.
So, sorry for the interruption, sir. I will
No
present
problem.
the case,
Please
sir.
start your presentation. Go to the second slide,
Yes, sir.
Dr. Vishwas. Yes, please start your
Sir,
presentation.
here is a male patient of yes, sir. Here is a male patient of age 72 years by name XYZ, resident of Bijapur, who is a retired bank employee, admitted with complaints of ulcerative growth of right cheek since 6 months. Sir. Next slide.
Vishwas, you have to advance the slides.
All right, 6 months ago. Patient was apparently all right 6 months ago, later developed an ulcer over right inner side of the cheek, insidious in onset, initially of 2 by 1 centimeter in size, not associated with pain, fever, discharge, but the ulcer was progressively increasing in size since last 3 months to reach the current size, associated with bleeding during brushing. Next slide, sir.
There is no pain in the ulcer?
Yes, sir, there was no pain on the ulcer, sir. History of caries teeth present, along with loosening of teeth. History of difficulty in opening the mouth since 1 year. No history of pain referred to the ear. No history of ulcer or growth in any other parts of oral cavity. No history of difficulty in moving the tongue. No history of halitosis. No history of excessive salivation. No history of altered voice or difficulty of speech. No history of dysphagia or odonophagia. No history of loss of weight or appetite. No history of trauma. No history of white or red patch in the mouth. No history of chest pain, cough, breathlessness. History of tobacco chewing since 40 years, not having the habit of keeping in mouth. History of alcohol consumption since 40 years, not a known case of diabetes, ischemic heart disease, tuberculosis, asthma and epilepsy. Known case of hypertension since 3 years and on regular medication. No history of similar complaints in the past. No history of prior radiation exposure, sir. Coming to personal history, so diet is mixed, appetite is normal, sleep is adequate and undisturbed, bowel and bladder normal and regular, habits, tobacco chewing and alcoholism since 40 years. Family history, no history of head and neck cancers in the family line. Treatment history, nothing significant. Allergy history, nothing significant, sir.
1 minute.
Okay,
what is the reason
here.
for the ulcer? Have you in the history? What is the reason for the ulcer?
Sir, he was having tobacco chewing since 40 years, sir.
He is not keeping it in
Slowly
the
the
mouth. That's
ulcer.
what you have written down. He is not keeping it in the mouth.
Yes, sir.
He is a smoker,
No, sir. He is non-smoker, sir.
tobacco chewing, and he is not keeping it in the mouth. So you mean to tell me
Not keeping in
that
mouth.
tobacco chewing and alcohol has caused this ulcer? Okay, go ahead. Go ahead.
Sir, yes, sir. Summarizing my history, sir. 72-year-old male presented with ulcerative growth since 6 months over right inner cheek, insidious in onset and progressively growing since last 3 months, bleeds during brushing with history of caries tooth or loosening of teeth present, history of difficulty in opening the mouth since 1 year, known case of tobacco chewing and alcoholism since 40 years, sir.
His ulcer is since 6 years,
Coming
6
to
months. His ulcer is since 6
6
months. And he has got a
Yes.
trismus since 1 year.
Yes, sir.
Before the onset of ulcer, he has got trismus.
Before Christmas was there from 1 year, sir.
Trismus is there for 1 year, reason not known, but ulcer is there since 6 months.
6 months.
Subsequently, you have got to answer this.
6 months.
No, we have to substantiate later. Okay. You are inviting one more extra question for the trismus because the ulcer is only 6 months and trismus is since 12 months. Okay.
Yes.
Go ahead.
Yes, sir.
What kind
So coming
of
to
Madhu?
yes, sir.
Dr. Madhu,
Yes, sir.
what kind of problem you are facing just from the history?
Yes, sir. Sir, he is having ulcer since 6 months, sir. And from 3 months, the ulcer started growing in size, sir. It has become ulcerative growth, sir.
Okay. So you think it is a malignancy or a benign? Just from the history.
Sir, because of chronic history of tobacco chewing, male preponderance, and elderly age group, I suspect a malignancy, sir.
Is it
But
painful?
there is no pain. It is not painful, sir.
Dr. Madhu, how can you explain the patient having the trismus followed by the ulceration? Can you explain that?
Sir, by history of tobacco chewing, sir.
So what happened by tobacco chewing?
Sir, there might be submucosal fibrosis, sir.
Yes. So that is the way you have to explain that, isn't it?
Yes, sir.
That the patient had a submucous fibrosis,
Submucosal fibrosis.
and submucous fibrosis is a pre-malignant condition. And
Yes, sir.
that has led to the malignancy now, isn't it?
Mouth opening has remained same? Mouth opening or well?
No, sir, there is a slight reduction in mouth opening, sir.
Okay.
What do you understand by trismus?
Sir, trismus is difficulty in opening the mouth, sir. Painful, and it is painful difficulty in opening the mouth, sir.
Painful. Is the trismus painful? Because of like a submucous fibrosis is there.
Yes,
But
sir.
what
Yes,
do you
sir.
understand by trismus? You know, when I'm asking you that what is trismus? Inability to open the mouth means like how much?
Inability to open the mouth, sir. Inability to open the mouth, sir, completely.
No.
He's not eating anything since 1 year. Has he lost weight?
Sir, no loss of weight, sir.
Then he's not able to open the mouth. What is he eating since 1 year?
Sir, there is no complete trismus, sir. It is moderate, sir. Mild to moderate trismus, sir.
No, first you have to tell what is trismus, and then you will say it is moderate to mild. Okay, trismus is that patient cannot put 3 fingers between the two incisors.
Yes, sir. Non-dominant hand, this index finger, middle finger, and ring finger should be applied, sir, like into the mouth. Non-dominant hand.
Distance of 3 centimeters between the two incisors, upper and the lower incisor. Okay.
Can you,
yes,
Dr. Madhu,
that is
can you,
trismus.
sorry.
And then it can be mild, moderate, severe one. Okay.
Dr. Madhu, can you tell us some causes of trismus?
Yes, sir.
Just enumerate them, name them. Common.
Yes, sir. Sir, peritonsillar abscess or quinsy, sir. Tetanus, eruption of molar tooth, or it can be malignancies of the oral cavity.
Any other viral condition, acute, which is seen in pediatric patient?
Sir.
Which glands?
Mumps, sir.
Mumps,
Sir, viral
yes.
viral mumps, sir.
Yeah. That is very common.
Yes, sir.
Go ahead.
Any other inflammatory condition because of some bacteria? Patient may die after that.
Sir, tetany, sir.
Tetanus, yes.
Tetany, lock.
Not tetany, tetanus.
Yes, sir.
Okay, tetany can also cause that.
Tetanus.
Yes, tetanus. What is the difference between tetanus and the tetany?
Sir, tetany is hypocalcemic condition, sir.
Yes, right. Okay.
Tetanus is infection, sir.
Correct.
Right.
Yes.
Okay, go ahead.
Go ahead with the examination part.
Yes, sir. Proceeding with examination, sir. After taking consent, the patient is made comfortable and examined in well-lit room, sir. Patient is conscious, oriented to time, place, and person, and cooperative, sir. So he is moderately built, moderately nourished. Hydration status is adequate. There is no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, and generalized lymphadenopathy, sir, except for cervical lymph node involvements. So coming to vitals examination, so temperature is afebrile, pulse rate is 72 beats per minute, regular, normal volume and character in right radial artery. BP is 130 by 70 mm of Hg, measured in right arm in supine position. So saturation is 98% at room air. Respiratory is 16 cycles per minute, sir. Coming to local examination, sir. Externally, the face appears normal. There is no asymmetry. Mouth opening is reduced, sir. No skin involvement over the cheek noted, sir. Internally, oral hygiene is poor. Multiple teeth loss present. Halitosis absent, sir. There is ulceroproliferative growth of size 5 cross 3 centimeters at right buccal mucosa and right inferior gingiobuccal sulcus extending from first premolar to right retromolar trigone, sir. It is oval in shape, margin is irregular, edge is thickened and everted and raised. There is no active bleeding or discharge from the lesion, no pre-malignant lesions in the oral cavity. Surrounding area is healthy. Opposite side buccal mucosa appears normal, sir. This is my inspectory findings. Next slide, sir. Next slide. On palpation, there is no local rise of temperature, non-tender. All inspectory findings are confirmed by palpation. Ulceroproliferative growth of size 5 by 3 centimeters, which is hard in consistency, doesn't bleeds on touch. Base of
wait. Hard in consistency? Ulcer is hard in consistency.
Yes, sir.
The entire ulcer, you mean to say?
Growth, sir. Ulcerative
growth is hard in consistency.
No, sir.
You said everted edges and all those things. Everted edges of an ulcer. 1 minute, Madhu. Everted edges of an ulcer will be hard in consistency. And since when we have started telling about the consistency of an ulcer? Consistency means what? Consistency means what? What I contain is consistency.
What does it contain?
What I contain is consistency. If there is a swelling, you'll be able to say that this is what I contain. Hard inconsistency for an ulcer doesn't fit in. And everted edges are hard in.
Sir, actually, I'm talking about ulcerative growth, sir. Ulcerative growth, sir.
Growth means what? Edges do not come out of that.
Whether you are describing swelling or ulcer, make it clear.
The photograph shows it is ulcer. He has to describe ulcer only now.
Yes.
Sir, base is indurated, sir.
The base, okay, I agree. How can the consistency of an ulcer? Base, I agree. Why? The base is a mucoperiosteum there in the oral cavity. That's why you find that the bases are always, most of the times, they are hard because it is mucoperiosteum. It doesn't separate the bone as well as mucus. They are adherent to each other. But consistency cannot be hard in consistency. Proliferative growth, I am able to see at the edge. That cannot be. Does it bleed and touch?
Sir, it doesn't bleed on touch, sir, but on brushing activities, he'll bleed, sir. Rigorous activities will bleed.
Brushing activity is touching or non-touching? You are splitting the
touching,
hairs.
sir.
It doesn't matter. Okay. Go ahead.
Yes, sir. Base of the growth is indurated and fixed
What
to
is base of
underlying.
what is base of the ulcer? Define base of the ulcer.
Sir, sir, it is the region on which the ulcer rests on, sir.
Yeah, it is where the ulcer sits on. Is base of the ulcer.
Rest.
Okay.
There is no other lesion palpable in lip and hard palate, sir.
What oral cavity you have
sir,
completed? You already come to cervical region? No. What has happened to the palpation of cervical region? What has happened to the tongue? You are presenting an ulcer in the mouth.
Yes, sir. Sir, tongue appears normal, sir.
Appears normal. What you see? What else tongue do? We are talking because of whom?
Yes, sir. There is no restricted movements in the tongue, sir.
It is called as a what?
There are no visible tongue movements, sir. Tongue protrusion.
What is ankyloglasia?
Sir, ankyloglasia is sir, inability to protrude the tongue, sir.
Madhu, can you show the picture? Just show the tongue
sir.
again. You think it is normal? What are those spots you are seeing over the tongue?
Sir, hyperpigmented spots.
Yeah, so that is normal.
Sir, because of poor oral hygiene, sir. He's a chronic tobacco chewer. Because of poor oral hygiene, the stains were there, sir, on the tongue.
If I say they are the erythroplakia?
No, sir. Erythroplakia will be red velvety lesion, sir.
So it looks like a
Has
red.
a clear.
It looks like a brownish red.
Yes, sir. That red velvety lesion, sir.
And there are patchy lesions are there. Okay. If it is only because of poor hygiene, it won't be the patchy lesions. You can see those are the patchy lesions. Multiple, like 2 or 3 lesions on the right side, 1 or 2 lesions on the left side.
Yes, sir.
Okay, so those are not a normal one.
Yes, sir.
Yeah. Okay, go ahead.
Yes, sir. Next slide. Sir, cervical lymph node examination, sir. Bilateral enlarged level 1A, level 1B lymph nodes measuring 1 by 1 centimeter, firmly consistent, mobile and non-tender, sir. Bilateral enlarged level 2 lymph nodes measuring 0.5 by 1 centimeter, firmly consistent, mobile and non-tender, sir.
Did you do a bidigital examination?
Yes, sir. For mandibular involvement, I've done.
No, man, you are already going to cervical lymph nodes. What about the local examination? Bidigital examination is extremely important for a mouth ulcer.
Yes,
Did
sir.
you
For
palpate the
mandibular
submandibular?
involvement.
ನೀನು ಯಾರಿಗೂ ತೋರಿಸೇ ಇಲ್ಲ ಕಣೋ ನಿಮ್ಮ ಪ್ರೊಫೆಸರ್ಸ್ಗೆ. You come directly from one room to the other room. How can there be an examination complete for an oral cavity malignancy with no bidigital examination being mentioned? Now tell me your findings of bidigital examination.
Sir, bidigital examination.
What do you look for in that?
Doesn't get in.
Go to that photo back. Show me that photograph. You tell me what did you look there?
Sir, examined bidigitally for thickening, tenderness, irregularity, and
thickening of what?
Fracture, sir. In the mandible.
Fracture.
Sir, thickening of.
No. Your thickening of what?
Muscle.
You look for thickening of what?
Floor of the mouth, sir. Floor of the mouth.
It is sit. Allappa, are you looking at the mandible or no mandible? Gums and mandible.
Yes, sir. I'm
no?
looking at the mandible. Yes, sir.
How do you say that this is thickened? To ascertain that this side is thickened, what are you supposed to do? किसी को abnormal कहना है तो normal देखना है पहले. किस तरफ देखेंगे?
Yes, sir. Opposite side. Opposite side.
Then how will you brand somebody as thickened unless you know what is the normal thickening of this side area, which is it looks normal here, at least with some are whitish patches. But to look for thickening of is it thickening of inner table of the mandible or outer table of the mandible or expansion of the mandible? Extremely important is if there is a lumina, marrow involvement of the mandible, you will be able to find the thickening of the mandible and expansion of the mandible also. This looks to be a quite advanced decision. You have not done a bi-digital examination. No. This is not pardonable. This is not pardonable. Tell me honestly, you have put your finger in the mouth? Honestly, be honest.
Yes, sir.
Honesty pays you a lot of marks.
Yes, sir.
Both the opposite side also you examined.
Yes.
Madhu, non-ending examiner no. I will come there to Alamin. I was there in Bijapur for 2 years. Probably you may be knowing. Okay, continue.
Yes. So on systemic examination, trachea is central, bilateral air entry, normal vesicular breath sounds bilaterally heard. There are no added sounds. On CVS system examination, S1, S2 are heard, no murmurs. Central nervous system examination, no focal neurological deficit. Per abdomen examination, soft, non-tender, and bowel sounds are heard.
Which intracranial nerve you examined? You name the cranial nerves, man. Hypoglossal nerve.
Hypoglossal nerve, sir. 12th nerve.
It is 12th nerve. What happens if there is a palsy of hypoglossal nerve on the affected side?
Sir, there will
How do you
be
make out the
deviation.
hypoglossal nerve palsy?
Sir, I asked the patient to protrude his tongue, sir. There will be ipsilateral deviation.
How do you make out which side of the hypoglossal nerve is paralyzed clinically?
Sir, on protrusion of the tongue, ipsilateral side deviation of the tongue will be there, sir. And there will be wasting of the muscles of the tongue, ipsilateral side, sir.
Tongue shifts to what side? What side?
Ipsilateral side, sir.
Okay.
Same side.
Did you examine that?
Yes, sir.
How
sir.
did you
Examined.
Did you palpate the tongue?
Yes, sir. I palpated the tongue, sir.
How will the tongue palpation? What is the finding that you make out? You palpate your tongue and say what it is. When you palpate your tongue, how it will be?
Sir, tongue will be soft in consistency, sir.
Hey, soft tongue, then you have to fluctuation. You have to demonstrate. The touching the tip of the nose and touching the functioning or contracted muscle tongue will be indurated. It looks like induration.
Yes,
and did you see? You have not examined oral cavity at all. You have to tell us what has happened to tonsillar fossa, both sides tonsils, and then you have to tell us the soft palate. You have to tell us the hard palate. You have to tell the. You have to examine about what is happened to the submandibular salivary glands and opposite vestibule of the mouth. There is so much inside the mouth, and you have come already to the neck. We are falling onto your neck now. You have not seen anything in the oral cavity at all. What has happened to the hard palate?
Sir, hard palate, soft palate, tonsils were appear normal, sir.
Did you mention that? But Ajay Khanna sir will not agree that all of them appear normal. The photograph shows they are not normal.
But see the patches on the palate also.
Yeah, that's what I'm telling.
Just show that. Again, show the picture. Again, show the picture. Can you see the patches over the palate? And what is happening to the uvula here?
Vulva is deviated to one side, sir. Affected side.
Deviated to, right side. Yeah.
Yes.
Dr. Madhu, how will you palpate the tongue? By putting outside or within the mouth?
Sir, no, sir, within the mouth, sir.
Why?
Because when we probe it will get contracted, sir.
Fine.
Sir, Vidyadhar sir and Kanna sir, maybe you can take it as a teaching session, sir. I think he finds difficult to cope up.
Yeah,
with these
yeah,
questions.
no problem.
So
No problem.
please guide them, sir. I think these
Sure,
boys
sure,
are all just moved into second year. So I
Yeah,
think
yeah, yeah. No, no problem, sir. No. Go
Yes, sir.
ahead. No, he's doing
Thank you.
well.
Yes.
No problem. No problem.
Yes, sir. Yes.
ಹೇಳಪ್ಪ ಮುಂದಿಂದ ಹೇಳು ಮಧು.
Yes. Next slide. Next slide. Next slide. Sir, I want.
How will you say those lymph nodes in the level 1? They are the lymph nodes or they are the submandibular gland?
Sir, I will. Sir, sorry, sir, I'm not able to get it, sir.
I'm asking you, you said there are lymph nodes in the level 1.
Yes. Yes, sir.
I say they are not the lymph node, but they are the submandibular and large submandibular glands are there.
How will you differentiate?
How will you differentiate whether it's the submandibular gland or whether it is the node, lymph node is there?
No, sir. Sorry, sir. I don't know, sir.
Okay, you have to do the bidigital examination.
By digital exam.
Okay.
How many submandibular lobe is having? How many gland is having? How many lobes?
2 lobes, sir.
Yes. And the
Yes,
lymph
sir.
node is?
Bilobed.
Yeah. So when you
Lymph
put
node is
both the finger,
deep.
you can palpate the deep lobe also.
Yes, sir.
Okay, so when you do the bidigital examination,
Yes, sir.
you will feel the gland from both sides.
Yes, sir.
Okay. But in the case of the lymph nodes, it will be felt only on the cervical side only.
Yes.
Submandibular cervical gland is U-shaped. It will be sitting at the mylohyoid muscle. Deeper one is above the mylohyoid. The lower one is inferior to the mylohyoid. When you do a bidigital examination, you will be able to feel both. If it is a lymph node, the other side you cannot feel because mylohyoid has come in.
Yes.
So it is extremely important to differentiate between submandibular cervical gland and lymph node because subsequently it helps you in clinical staging. You have to ensure that it is lymph node only, then it will help you for clinical staging and further management of the case. Okay.
Sir, summarizing my case, sir. Here is a 72-year-old male presented with ulcerative growth since 6 months over right inner cheek, insidious in onset, progressively growing since 3 months, bleeding, brushing with history of caries teeth and loosening of teeth, history of difficulty in opening the mouth since 1 year, known case of tobacco chewing and alcoholism since 40 years. On examination, mouth opening is reduced, oral hygiene is poor with multiple teeth loss, an indurated ulceroproliferative growth of size 5/3 centimeter at right buccal mucosa, right inferior gingivobuccal sulcus, extending from first premolar to right retromolar trigone, oval in shape, irregular margin, edges thickened, everted, raised, and hard in consistency, fixed underlying bone, bilateral cervical lymph nodes 1A, 1B, and 2 lymph nodes are involved.
Suggestion, you should also write dental formula. What are the teeth you are still able to see? You have said some you have to write the dental formula. ICPM on both sides. Okay. Okay.
Yes.
Dental formula, we will be able to know how many teeth he has. If you do not mention how many teeth he has. Okay, go ahead.
Yes. My provisional diagnosis would be, sir, carcinoma of right buccal mucosa with bilateral cervical node metastasis, sir. Clinical stage would be T3, N2C, M0, sir.
Why do you say T3?
Sir, because tumor is more than 4 centimeter in size, sir.
Okay. Why do you say N2, N2, N2C?
Sir, N2C because there is metastasis in bilateral lymph node present, sir. And it is less than 6 centimeter in size, sir, dimension.
Would you like to say
And there is no.
Would you like to say any differential diagnosis?
No, sir. I'm.
You must come out with that. Confident.
Malignancy.
Differential diagnosis. This is malignancy only. Only thing is we have got to have a histopathological evidence. How will you confirm your?
Yes, sir.
Go ahead with your investigations.
Yes, sir. Next slide, please. Sir, to confirm my diagnosis, I go with the wedge biopsy, sir. Wedge biopsy from the margin of the ulcerative.
1 minute. Wedge of an edge. It is an edge biopsy. Take the wedge from the edge. You understand?
Yes. Yeah. Yes, sir.
So what is the reason of taking the biopsy from the edge?
Sir, usually edge contains. Yes, sir. Sir, edge contains normal and abnormal cells, sir. One reason. And at the edge of the ulcerative growth, there will be more proliferating activity, sir.
So more mitotic activity is there. Okay.
Yes.
We'll get the more mitotic activity at the edge because that is the place where the cancer is proliferating.
Growing. Yes.
And not from the central part because there's necrosis is there.
Yes. It contains necrosis.
Okay.
Then USG of the neck, sir, for any lymph node examination in the neck, sir, for any lymph nodes in the neck, sir. Then if there are lymph nodes, enlarged lymph nodes, I could see, I go with the USG guided FNAC, sir. USG guided FNAC of lymph nodes, sir. Then I'll proceed with CECT, sir. CECT of head and neck, sir. For extensions, to know about extensions of my disease, sir. Then I proceed with MRI, sir, for any soft tissue involvement, sir. Then I go with orthoentomogram, sir, just a protocol to see mandibular involvement, sir. Then I'll take dentist opinion, sir, for prosthetic care, dental, like teeth extraction and all, sir. Then indirect laryngoscopy for any synchronous lesions, sir, to know about synchronous lesions. Then I'll proceed with all routine. Then I'll proceed with all routine investigations, sir, for anesthetic fitness.
Madhu, why you are doing the CT scan and the orthopentomogram both?
Sir, if the patient is not affordable, first to rule out mandibular involvement, I go with orthopentomogram, sir. Teeth sockets and mandibular involvement.
No, but in this, your management protocol, you have first done the CT scan and then you are after that you are going for the orthopentomogram. In the CT scan, in the bone window, you can see everything, you know?
Yes, yes.
Okay, in the CT scan, when you do the bone window, you can very well see everything of the mandible which is there. So if you're doing the CT scan, it is not necessary to carry out the orthopentomogram.
Yes.
Okay. And
yes.
MRI is for what purpose?
Sir, actually for soft tissue involvement, sir. For soft tissue involvement and perineural spread, sir. To rule out any
usually in the oral cavity, MRI is done for which lesion? In the oral cavity, for which lesion you usually, you can do the MRI for any lesion, but which is the commonest lesion where you would like to do the MRI? It is for the tongue. If there is a lesion, the tongue is there.
Sir, any swellings arising from any swellings arising from the tongue and the floor of the mouth, we suggest MRI, sir.
Right. Yeah. So for the buccal mucosa, it may not be required, but for the tongue and for the floor of the mouth, you require to have the MRI.
Yes.
Dr. Madhu, which investigation is helpful for staging the tumor out of this?
Sir, for staging the tumor, CECT head and neck is helpful, sir.
Yeah, so it is essential for it. Correct.
Yes, sir. CECT head and neck, sir.
Madhu, what is the unit of the MRI?
Sir, Tesla, sir.
Tesla. Good. And what is the unit of the CT scan?
Hounsfield unit, sir.
Good. Hounsfield unit. Good. Yeah. Okay. Why do you call a laryngoscopy as an indirect laryngoscopy?
Sir, because oral cavity is visualized using the mirror, sir. Actually, the instrument mirror, which contains mirror, it is used for visualization of oral cavity, sir. That's why we call it indirect laryngoscopy, sir.
And what is a direct laryngoscopy?
Sir, direct laryngoscopy, directly laryngoscope is applied, sir. It is usually done in emergencies, sir. Anesthetists usually in emergency or anesthesia, sir, they will do, sir.
Either
Directly
anesthetist
laryngoscopy.
directly sees that, but can a ENT surgeon can also do the direct laryngoscopy?
Yes, sir. They can do, sir.
Fiber optic, hai na?
Yes.
If you use the fiber optic, you can do the direct laryngoscopy. Okay.
Yes, sir.
So what do you plan now? How do you manage this case? You have done all these investigations, it comes as malignancy. With the stages that you have mentioned, it is, yes, it fits into that stage. What do you want to do?
Sir, actually, my patient is having advanced lesions, sir.
Okay.
Belongs to stage 4. That's why I go with the
investigation
wide
shows
excision of the.
No, investigation shows the bone is involved. The investigations have
Yes,
been
sir.
done.
Yes, sir. Investigation shows bone is involved, sir.
Okay.
Right side of the mandible is involved, sir.
So what do you want to do?
Sir, wide excision of the primary lesion with 1 centimeter margin, sir.
Bone is involved. You want to remove the bone also?
Yes, sir. Marginal mandibulectomy or segmental resection of the mandible, sir. Along with neck node dissection, sir.
How do you cover up the deficiency? You have taken out the mandible. You have taken out the mandible. How will you cover the deficiency?
Reconstruction.
Reconstruction
Yes, sir.
with what?
By reconstructing. The reconstruction with sir, osteomyocutaneous flap, sir.
From where you bring it?
Sir, usually the most commonly used one is radial artery forearm flap, sir, along with the section of radius, sir.
Anything else locally?
Yes, sir. Sir.
Okay. Doesn't matter. You have an idea that
soft tissue covering can be flap. Yes, sir.
Can a prosthesis be used?
Yes, sir. Usually prosthesis is used, sir. Usually titanium screws are used, sir. But usually natural ones are preferred over. Sir, titanium screws are used, sir.
Your voice is breaking, man. I'm not able to continuously. Yeah.
Sir, titanium plant can be used. Titanium implants can be used, sir. Prosthetic titanium implants can be used.
Any other modality of treatment you would like to suggest?
Yes, sir. Rib ilia can be also implanted for.
What is commando's operation?
The next question that is.
Sir, commando's operation is used in tongue malignancy, sir. Removal of the lesion with the margin and removal of lymph nodes and hemimandibulectomy, sir.
What does the commando stands for?
Sir,
what does the commando stands for?
Commando.
It is not somebody's name, it is the name of the hospital. Okay.
Commando stands for combined mandibulectomy and neck dissection operation.
Yes, sir.
Combined mandibulectomy and neck dissection operation. That is the commando.
Yes. Yes.
Now, in this patient, you are saying that you can do a marginal mandibulectomy. Do you think we can be done in this patient, the marginal mandibulectomy? Almost all the teeth
No,
are
sir.
gone. Edentulous patient, है ना?
Yes. Yes. Yes, sir.
So in a edentulous patient, it is not possible to do the marginal mandibulectomy.
Yes.
Okay. You know, you understand what is marginal
Segmental
mandibulectomy? What do you understand by marginal
Yes,
mandibulectomy?
sir. Sir, marginal mandibulectomy where the only alveolar part is removed, sir. Alveolar part of the mandible is removed, sir. From the margin of the mandible, only alveolar part is removed, sir.
Not necessary, है ना? It can be upper marginal, it can be lower marginal.
Yes.
Okay, you can remove
Preserving the
upper
lower
margin or
part
you
of
can
the
remove the
mandible.
lower margin also. The important thing is
Yes,
that to preserve the mental canal, the mandibular canal which is there, where is running the inferior alveolar nerve which is running there. So you have to preserve that.
Yes.
Okay. So in a case of edentulous type of the mandible, you cannot do that.
Yes.
So what else you can do then? What are the other
Sir, we
types
can
of
go for
mandibulectomies?
sir, segmental mandibulectomy, sir. Segmental mandibular section, sir.
So you can do
Yes,
a
sir.
segmental mandibulectomy. Okay.
Sir, hemimandibulectomy is also done.
Yes. And for the repair, you said the radial artery flap, isn't? Now, for carrying out the radial artery flap, which is there, you need to have the microvascular setup with you.
So you
If
require
you
a
do not
plastic
have the
surgeon.
facility for the microvascular, then what are the other various types of the osteomyocutaneous flaps which can be used?
Sir, compound groin flap, sir, with deep
Again-
circumflex iliac vessels.
Again, you will require the microvascular for the groin flap.
Yes.
If you do not have
And
the technique
free
of having the
fibula.
microvascular, can you use something else?
Yes, sir. Free fibular flap can also be used, sir.
Again, it will require a microvascular.
Sir, rib graft, sir.
No. You require to have something which is in the loco-regional area.
Yes, sir.
So the most important one is the pectoral myocutaneous flap.
Pectoralis major myocutaneous flap.
You can take the myocutaneous flap, you can take one rib with that, or you can take the clavicle, or you can take the upper part of the scapula.
Shift should occur.
All these can be rotated along with the local myocutaneous flaps. There you will not require the microvascular surgery.
With the vascularity, it will be shifted, not microvascular surgery and joining them. If the mother, the flap should have vascularity from the base where it is being set up. You require a plastic surgeon. Okay.
Yes, sir.
Anything else? If he is not fit for surgery, what will you do?
Sir, we proceed with radiotherapy, sir.
What kind of radiation?
Sir, usually brachytherapy, sir.
What is brachytherapy?
Sir, brachytherapy is source is instilled inside the lesion, sir.
What are the other two types of radiotherapy? What are the other types of radiotherapies?
Sir, external beam radiotherapy, brachytherapy, teletherapy. Sir.
External beam radiotherapy is teletherapy.
Teletherapy, yes, sir.
Yeah, brachytherapy, teletherapy. That's the other one.
Sir, now, sir, advanced modality.
Anything given IV?
Sir.
The hyperthyroidism, uncontrolled hyperthyroidism, patient not being fit for surgery, what will they do? Systemic irradiation.
Yes, irradiation.
Systemic. So there are three types of radiotherapy. They use teletherapy, brachytherapy, and systemic irradiation. Okay. So you have facility for brachytherapy in Bijapur?
No, sir. We don't have a facility, sir. We refer to Hubli Center.
Madhu, when you say the brachytherapy,
yes, sir.
Yeah, you said that you have to put inside the tumor or something, you know?
Or close to the lesion, sir.
Yeah. So what are the various types of brachytherapy?
Sir,
if it goes inside the lesion, it is called at the
sir.
interstitial.
Interstitial.
Interstitial brachytherapy. Okay.
Yes. Yes.
Can you tell any lesion where it is not inside, but it is put surrounding the lesion?
Yes, sir. No, sir, I don't know. Sorry, sir.
In the cervical cancers.
Cervical.
In the cervical cancer and the penile cancers, where you put the mold there.
Yes.
Okay, there you are not putting inside the tumor. Here you will put it inside the tumor, but there you can put inside the mold there. In the penis and in the cervical cancers. Okay.
You have done well. Some more improvement is necessary. And also please learn how to handle computer presentations. Man, it is your age now, not our age. And you face some kind of a difficulty to start with. However, you should say thanks to your colleague who is doing this work, and your presentation has been good. And from now on, you start presenting every day in the room with your friends, so that you will be increasing your vocabulary. Also, communication skills you will develop. I am very happy that you have come forward to present at the national level. You must thank Dr. Kanagavelu sir for having given you an opportunity. And Sajjad Ali sir, he was a very close friend of mine. Convey my regards to him. Sajjad Ali, I had come to your department and delivered a lecture about ultrasound for surgeons. I don't know whether you were there or not. So, convey my regards to Sajjad Ali sir and all the teammates. It is time that we should say goodbye. Kanagavelu sir to take over.
Kanna sir, any closing comments, sir?
Yeah, Madhu, whenever you get a patient with a oral cancer, the first choice of treatment is always the surgery.
Surgery.
And in that case, when you're doing the surgical treatment for that, it is usually the wide excision. 1 to 2 centimeter wide excision is carried out. And then the question comes of the repair. And repair in the case of the oral cavity which is there, it is in 3 layers. One is the lining, second is the support, and third is the cover. So lining means the mucosa. Cover means the skin. And the support means the bone. In a good number of the cases, you can just give the patient the cover and the lining. But if you are sure of that you have done a good resection, R0 resection has been done, then you can give the patient the support also in the form of the various type of the bony process which are there, or various type of the prostheses which are there, the titanium plates and all those things which are there. You can use that. Okay. So you have to know, like in this patient, if you go for the wide excision, how you are going to give the lining here?
Sir,
how will you give the lining?
Sir, primary closure, sir.
No, you won't be able to do a primary closure. Such a big lesion. You say it is about 7 centimeter lesion is there. You won't be able to close primarily. You have to always give in this patient. You may close the cover, the skin may be covered in the patient, but not the mucosal part. Because the skin is not involved, so probably you can cover the skin directly, but not the lining there. Lining will require some type of the
flap of
yes. So majority of the time you use some loco-regional flap for that.
Yes. Sir.
So you use the loco-regional flap, or you can use a microvascular flap for that. And like you are giving the radial artery or the groin flap or the fibula, you can use the flap for that, for the lining purpose. But in a good number of cases, you will use the most common muscle which is there based on that, which flap is there, where you can give the lining.
Yes, sir. Pectoralis fascia and pectoralis major muscle, sir.
Either a deltopectoral flap, or you can use the pectoralis major flap. Yeah. So by that you can give the lining. Some people also use the forehead flap.
Yes, sir.
And the most important thing which is there, the flap which you are going to use should be hairless. Okay.
Yes.
So you can not use a hair inside the oral cavity.
Yes.
Right. Then if the tongue is available, you can use the tongue also. The tongue flap can be used for the lining purpose. And then support we have discussed, and the cover again, in this case, it can be done primarily, or you will again require some flap, and you can use the same deltopectoral flap or the pectoralis minor flap, major flap, or you can use the forehead flap for that. Okay.
Yes, sir.
Yeah. Dr. Kanagawal, please.
Yes, sir. Thank you very much, sir. Thank you. I think it's by another chance we can give another 2-3 months later, he'll be able to do justice, I think. And I should thank Nishikant sir for taking all the efforts to get the boy trained. I'm sure we will look forward for the next week for yet another case presentation. With the permission of the faculty, I'll call the session a close. We move to the next Friday for yet another session. Thank you very much, sir.
Thank you, sir.
Thank you, sir. Nishikant sir, thank you, sir. Vishwas,
Thank you, sir.
thank you very much,
sir.
Vishwas.
Yes, sir.
Vidyadhar sir, thank you very much. Thank
Thank
you,
you,
sir.
sir.
Good night, sir. Good night, everyone.
Good night. Good night.
Good night, sir.